a keynote conversation between Professor Sir Mike Richards, Chair of the UK National Screening Committee in CQC, with our CEO, Bea.
Could we have one more mic?
Mike has a mic. I wanted to say you heard it here first from Sir Mike about self-sampling being rolled out, so we won't quote you on that.
Mike, sorry. Right, let's get that sorted. Thank you. Can you hear me now? Is that all right?
Brilliant, thank you. So I definitely want to get the audience involved, because I'm sure there's a lot of people here who want to ask you a lot of questions. But before we get going, Mike, I'd love to start actually, because you've been in cancer screening and cancer for a very long time. Not that it looks like that, but
thank you.
For all of us in the room, Mike, talk us back about what the cancer landscape looked like when you first started working in cancer.
So I was an oncologist originally for quite a long period of time, but then 26 years ago, I was appointed as National Cancer Director, the first time there was a National Cancer Director. And even before that, I had had real concerns about how cancer services were delivered. And I had effectively made the decision, could I either go on dealing with a small number of patients in my medical oncology practice, or could I do something on a bigger scale? I mean, it all came about actually because of being phoned up by a colleague in, being phoned up by a colleague in another city who said, look, I've got a 32-year-old with breast cancer, should I give her adjuvant chemotherapy or not? So to which I said, well, had it spread to the lymph nodes? Well, you may or may not know, but the surgeons in this city do not actually remove the lymph nodes. So the next thing I said was, well, what was it like under the microscope? What grade was it? Oh, the pathologists in this city don't grade breast cancers. And I said, well, how big was it? And they said, unfortunately, that wasn't recorded. Now, that's a real story. And I thought, here am I sitting in an ivory tower. I got that information on every single patient that came through my clinic. My job was a doddle in comparison with his job, where he had to guess. That started me off thinking, do we have variation in the way we provide cancer services? And I worked with what was then the Thames Cancer Registry, which was the quarter of the country. And it was quite clear that there was mayhem out there, the different things being done in every part of the country. And that's where I started agitating and saying we need to do something about this. And first of all, I wrote some guidance about how breast cancer might be managed. Then I went on agitating. And with the Department of Health, they have two options, really. They either think you're such a nuisance, they get rid of you, or they say, actually, we could do with you, come and work on the inside. And I think I was in the latter category. And so I became National Cancer Director in '99. A lot of that was about the hospital services to begin with, getting people working in multidisciplinary teams. It may sound obvious now, but it wasn't happening. You know, the surgeons weren't talking to the oncologists, so the patients didn't get the adjuvant chemotherapy or radiotherapy. And nobody was reviewing the pathology to say, yes, actually, this one does need this. So a lot of it was focused on secondary and tertiary care, always aware that we weren't doing enough about primary care. I claim to be the first one that worked out that a GP only saw 8 patients a year. It wasn't very difficult. I divided the total number of cancers in the country by the number of GPs, and 8 was the answer. So I'm quite glad to hear it's still the same figure, or roughly speaking, the same figure. And that basically meant it was 1 breast cancer, 1 prostate cancer, 1 bowel cancer, 1 lung cancer, and all the rest together were the other 4. And so really, really rare. But we have struggled to know how to support GPs. And it's no good just berating them and saying this is not good enough. How do we actually support that? And I don't think we did terribly well on that over the years that I was National Cancer Director, but I always wanted to do more.
Brilliant. And you talk about in that is going from an oncologist, seeing patients, potentially seeing patients who come to you quite late and thinking, oh God, why didn't we do something earlier? Seeing variations in treatment, and now putting on this national director hat on. Talk to us about some of the challenges that were unexpected in that role and some of the brick walls or the status quo that you really had to fight to overcome.
Well, actually, even the question of early diagnosis was not fully accepted. Even before I became National Cancer Director, I had done a study at Guy's, which is where I was working, where we had data on how long people had had symptoms for, as well as all the other data. And it was quite clear that those who'd had longer symptoms before they came had worse outcomes, even if you measured it from the date of first symptoms, so you got rid of the lead time effect. But of course, that came from one hospital, so nobody believed it, typical. And so I then said, well, maybe we need to do a systematic review. I applied to the Department of Health for funding for a review, and they sent it out to 2 peer reviewers to see if the proposal was worth doing. One came back saying, no point in doing this research. It is so obvious that delays make a difference. And the other came back and said, no point in doing this systematic review. There is no way that a delay of a few months can make a difference. And I went back to the Department of Health and said, that's why I want to do the systematic review. And believe it or not, the first paper that was written on whether delays matter was in 1906. Now, I challenge anybody in the audience to find a systematic review that goes back further than to 1906. My claim to fame is I think I've done the longest. And there were 80 papers over 80 years. Only one of them really said the opposite. But that was the one that clinicians quoted the whole time. I can tell you now, it was Bloom et al. 1950. But all the massive amount of evidence was in the other direction. So the fact that now it is national policy that we should have earlier diagnosis is a very good thing. So that was the first. I think the recognition, which actually came from politicians, that faster diagnosis, in other words, things like the 2-week wait, the 62-day target, they were very aware of that from what they had picked up from patients. But this business of earlier diagnosis has taken time, but it is now absolutely there. So that was the main obstacle. Most of the rest of the time, actually, I had strong support from prime ministers, I had strong support from secretaries of state, and so my job, I had influence. I didn't have the authority, they had the authority. But if you've got support from above, it can go a long way.
And when was the systematic review released?
Oh, that was released late 1990s.
And what were the key recommendations you had made in that paper, or the key findings?
God, you're asking me to remember a long way back. I'm very proud to say it was in the Lancet. So, we did 2 things actually. We did a systematic review of do delays matter? Answer yes. Second one was why do patients delay? And we reviewed the literature on that. And there were things like having a past psychological history or psychiatric history was a major factor, but there were a number of other factors. So I think what we wanted to do was just get it on the agenda and say, look, this matters. And I still think it is one of the key elements of why we have worse survival rates in this country than other countries. Why do I say that? Because it's not just our 5-year survival or 10-year survival that's worse than other countries, it's our 1-year survival. And actually, it's even less than that. There was a study that was done with the Scandinavian countries, and our survival 3 months after diagnosis is worse than theirs. Well, it's quite difficult to believe it's anything else apart from a later diagnosis. So that's why I keep banging on about later diagnosis.
From that publication then, which was, I think, if I can do the maths, about 30 years ago, to today, what were your hopes then in that publication to, if you went back in time, or vice versa. Where would you think the country would be today compared to where it is now?
I was asked almost that same question in February 2000 by Tony Blair. Well, actually, he asked me 5 questions. He first of all said, is cancer as bad in this country as people say it is? And I said, yes, we've got the evidence. Why is it so bad? And that's when I then said, I think it's a combination of things, but late diagnosis is one of them, but variations in treatment are another. He said, what are you going to do about it? So I outlined a whole lot of very good things to do about it. I got those 3 answers right. He then said, well, how long is it going to take and what's it going to cost? I'm afraid I got both of those wildly wrong. Because I suppose if you asked me back in 2000, where would we be in 2025, I would say, well, surely we will have eliminated the gap with other countries. We would be there with all the best countries in the world. And so the fact that we're still not irks me a lot.
And on that, what do you think we're still doing wrong?
Well, I think a variety of things. I think we're not making it easy enough for GPs to recognise which patients need further investigation. We're certainly not giving GPs good enough access to diagnostic tests. If you compare us with places like Australia, it's much, much easier for people to get a diagnostic test. You do know that another part of my working life is trying to get better diagnostic services in the country, and that's what motivated me to do that. And so I think those things really matter. And I still think it's not only on that first phase of the journey, it's also variations in how we treat people subsequently. But I think we've still got to go on all fronts, basically.
We've talked a lot about primary care, and often a lot of some publications and research talk about the GPs. We have a gatekeeping system here,
yep.
Similar to some European countries who do face the same challenges, but those who have better outcomes often have 30-minute appointments. They don't see obstetrics or gynecology, they don't see pediatrics, they just see adult medicine and things like that. How do you think those types of differences in environment, can we learn from them? Is there an opportunity to consider what investment needs to be done in general practice as a result? But also considering that on one hand, we often hold general practice accountable for gatekeeping, but at the same time, we see on the financial side, it props up the NHS. 90% of all clinical activity happens there. If the door was wide open, I'm sure it'd have a big impact on services.
And that really leads us into what is this government trying to do about it, and the 10-year plan that's just come out, and the 3 shifts. We could have a little quiz and see if everybody in the room can name the 3 shifts, but maybe instead of doing that, I'll try and remember them myself. Firstly, hospital to community. Much easier said than done. But do I believe it really matters? Yes, I do. So we've got to give more support to the community. It's no good just dumping everything on the community. We've got to give support. That's one of the shifts. Analog to digital. Well, see the signs could be part of this. There's lots that we need to do there, but I think we all agree that is a necessary part of it. And then from treatment to prevention. I think treatment to prevention is meant in a very broad sense. So that is meant, yes, it's more about primary prevention, stopping people getting heart attacks in the first place, stopping them getting cancer, as we've just been hearing about, but also screening and early detection clearly comes into that, but also preventing people bouncing in and out of A&E, and when they don't need to be doing that. Another of my interests is in end-of-life care, where we know that, actually, fun enough, the evidence base for shifting from hospital to community is as strong for end-of-life care as it is for any other area. It's not me just saying that. The Nuffield Trust have done the evidence for us on that. So I think my next request of See the Signs is, can you help us detect the people who may be approaching the end of life? I realise you've got your hands full at the moment sorting out the diagnosis, but I'd hate you to think that I was going to leave it at that. You know, once you've sorted that, just sorting out the other end of the spectrum would be very valuable.
Absolutely. And on that note, before we jump into the 10-year plan, often you see across, you mentioned like the 14-day, we have the 28-day, we have the 62-day. And in the last plan, the long-term plan, we had the big ambition of the 75%, getting to early stage diagnosis. Why do you think we didn't meet it? Do you think we were too ambitious, or do you think potentially we spent money, time, investment in the wrong places, or both?
I certainly believe and want to see earlier diagnosis. Whether 75% was the right figure, I rather doubt. If you look at the current trends, it'll probably take us well past 2050 to get to that, if not 2060. So I might advise a government to have a different target, because yes, we want earlier diagnosis, but partly, well, as much as that, what we want to do is reduce late diagnosis. The patient who was presented earlier, where they've been to the GP hundreds of times or whatever, why wasn't it picked up earlier? Reducing late diagnosis, it's late diagnosis that people die from. And if we could eliminate or reduce that, and so maybe we need to have a bit more emphasis on how can we reduce the 3s and 4s, or even just the 4s, stage 4s, and how can we reduce the emergency presentations. We know that 19% or something of all cancers are diagnosed as emergencies, and they have a terrible prognosis. So what can we do? Some of them won't ever have come near the doors of a GP, but can we identify who those are most likely to be? Are they the Roma community? Just thinking about what we've just been hearing about, are they other communities? And how do we get to them more proactively? But equally, which are the ones who have come to general practice but weren't picked up? So I think we need a twin-track approach. So I would actually like to see the new cancer plan have much more of a focus on reducing late diagnosis. That would be my advice to government. Whether they'll take it or not, I don't know.
No, that's brilliant. We often cite this study done by the BMJ where they investigated presentations in A&E, where they found that 2/3 of those patients actually presented to their GP first with accelerating symptoms and then ended up in A&E. So again, an opportunity to intercept these patients and potentially something that Jess's rule could help with.
Yep.
Because the long-term plan and the 75% goal became something that was everyone's North Star.
Yeah.
We all appreciate that when we have numbers, and I wonder if the lack of numbers in the recent 10-year plan is intentional. But when we have numbers, we do get obsessed with numbers. We were obsessed with the 14-day target. We're obsessed with the 28-day target. We're obsessed with the 62-day target. So there's this quote by Don Berwick, which is like, this, systems are designed by the results you measure, and I would love to know, what metrics do you want to see in this upcoming cancer plan that you think are the right things we should be measuring to help drive either innovation and investment?
So I would keep the 62-day target. Why? About 20 years ago, a patient said to me, Mike, it's not the 62 days that matter, it's the 61 nights in between. And that stuck with me. Time of huge anxiety for patients. So that in itself. We now do have evidence that if you go beyond 62 days, actually your outcomes are worse as well. We didn't have that when we brought in the 62-day target, but we do. So on both fronts, let's keep that. The sort of switch in emphasis from the 14 days to the 28 days, either to diagnosis or exclusion of cancer, that really reflects the fact that there are now different routes in. So if somebody has a raised PSA, maybe the first thing that should be done is an MRI, not a referral to a urologist. What's the urologist going to do? They're going to say, have an MRI. You know, that's a waste of a visit, in my view. So by saying from referral to getting to diagnosis, that does make sense to me. So let's keep those. Let's keep a focus on either earlier diagnosis or reducing late diagnosis. I'd love to see a target for actual numbers of stage 4 cancers reduced. If anybody wants to join that campaign, let me know, because I think that's where we should be looking for. What can screening do to help us on that? What can see the signs do to help us on that, etc. So, and how can we reduce those emergency presentations, which often are late stage?
I would love to be performance managed on emergency presentation rates and reduction in stage 4. And I hope everyone else here would agree with that as well. I think that's two fantastic indicators. On cancer, we know it doesn't affect people equally, but it also, you know, there is a lottery based on the type of cancer you might be diagnosed with what pathway you end up. So we've got colleagues in the audience from Pancreatic Cancer UK, who, you know, for those patients haven't seen much impact for over 10 years. In other cancer types, we've seen significant gains in survival. How do we shape services when it's the case that obviously incidence and prevalence of these cancers are different, but at the end of the day, we want survival to be equal across these patients, which is hugely challenging as a commissioner?
First thing to say is I don't have the answer to pancreatic cancer. I wish I did. But I think a focus on earlier diagnosis generally and getting better access to diagnostic tests will help. We wait to see whether new tests like multi-cancer early detection tests are good. We really don't know yet, but you will know that there's a very large randomized controlled trial, the Gallery trial, which we will have the first results by this time next year. Then they'll be coming the way of the screening committee. And we are already thinking, how on earth do we assess a blood test that could potentially pick up 50 different cancers? So I think we're very interested in it, but we do have to wait to see if it actually has the impact, either in reducing stage, which will be the first set of data we get from that trial, and then ultimately, does it reduce mortality? And the Gallery product will only be the first of several. And so I am optimistic that there will be other ways of detecting cancers early, because pancreatic is a particularly difficult one.
And then one of the things, Mike, that we talk about a lot is about funding. And some people say that cancer gets a lot of funding already. But when we correlate that with the improvements we see in other health conditions, if we think about how many gains we've made in infectious diseases as a country, how many gains we've made in cardiovascular disease, and as you mentioned at the beginning, we've probably not seen those gains in cancer in the same way. What do you see as maybe something that we need investment in, and where would you say, I think you mentioned about diagnostic, and I think people on the panel, especially primary care providers on the panel, talked about the fact that they can't even request CTs, they can't request MRs, and these are trained professionals working at the top of their license for 15, 20 years that still have to ask permission. So there's low-hanging fruits, but there might be higher-hanging fruits that you think that we need to start investing in.
Just on the diagnostics, because it is one of my little hobby horses, I was asked to do an independent review of diagnostic services in the NHS. Actually, I was asked to do it just before the pandemic, and then we published it in October 2020, so after the first peak of the pandemic. What was absolutely clear was that we didn't have enough diagnostic capacity in the UK against all the other OECD countries. We were right down at the bottom end of the spectrum. I think Hungary and Mexico might have been lower, but that was all. And actually on one of either CT or MRI, we were at the bottom. So clearly we needed more capacity. And then secondly, we needed to do things differently. And that was part of the drive to bring more of diagnostics out into the community, hence community diagnostic centres. And we now have 170 of those. Are they working fully yet? All of them? No. Are they actually taking on quite a bit of the additional load? Yes. If you ask me, do we need to go further? Absolutely, yes. Diagnostic demand across almost everything is going up by more than 4% per annum. So yes, we're going to need more. We need to be better at what tests for which groups of patients. Do we need to give GPs better access? Yes, but we also need to help GPs know which test it should be. See, the signs might help there. So that we get the test being used optimally. And so I have no doubt that we do need more investment there. And I think that is probably understood by government because, the one overarching target, which is to get the 18-week target back down to where it should be, I think they do now understand that they're not going to do that without diagnostics. So I'm hopeful that will happen. Of course, we need more funding also in radiotherapy, in chemotherapy, in better surgery, and if we're going to do robotic surgery, which I'm fully supportive of, but let's make sure we train our surgeons to do it well. Training surgeons is very cost effective. We've done that with laparoscopic surgery. They remember it for life, they learn for life. One program teaches a surgeon for life. Really good thing to do. So I'll be pushing that with robotics as well. So there's lots we can do. I think what we need to do, if you went to the cardiovascular people, they'd say, oh, we get left behind by cancer. And so I think it's more saying, what can we best do for cardiovascular disease and what can we best do for cancer? And you will have noticed that the 10-year plan does not have long sections on cancer, on cardiovascular disease, on mental health, etc. I think that was a deliberate choice. It doesn't mean there can't be that emphasis post-plan. So we've got, for example, that cancer is in the lead in having the fact that there will be a cancer plan, as it was back in the year 2000. But the other little hint that's in the 10-year plan, in the noughties we had national service frameworks, and heart disease, stroke, mental health all came into that. They slightly changed the wording. They're calling them modern service frameworks, but it's there. And I think that's a hook that we will need to use to say, across a whole lot of different conditions, what can we do better and how? And very much that's got to start from the community, from primary care.
Amazing. And I would like to now open it up to questions from the audience. Or I can keep going. Yeah, okay. David.
Fascinating discussion. It would be remiss of me not to ask about prostate cancer screening, both as the son of a prostate cancer current survivor who is very lucky to be found extremely early. My father is 17 years post-diagnosis, but he is the exception, not the rule. And I know friends and colleagues at Prostate Research UK are lobbying hard for prostate cancer screening. So sorry to put you on the spot, Mike, but...
That's quite okay. They most recently lobbied me yesterday. So that's quite up to date. And I have been lobbied in my own home by a recent ex-Prime Minister. You can probably guess who that is, because I have a home up in North Yorkshire. You can put two and two together and work out that was Rishi Sunak. I'm absolutely... Where are we with that? It is actually a very difficult one. Would I love to see screening if we can demonstrate that the benefits outweigh the harms at reasonable cost? We will recommend a prostate screening. The benefits are, according to the studies that have been done, not as dramatic. I think there are benefits. I'm not saying there aren't, but they're not as dramatic as they are for some other cancers, like maybe colorectal cancer. And there are potential harms. So you get a raised PSA, MRI, well, that's hardly a harm, but biopsy is not a pleasant procedure, and so that is a harm, and it can carry infection risks. It used to be thought that, until very recently, people have been saying, but transperineal is much better than transrectal biopsy. Actually, there's now some evidence that it's 6 of one, half a dozen of the other. Then you find that the person has got cancer, and a lot of those cancers will not be so-called clinically significant. But then the person knows they've got a cancer. It's a bit akin to ductal carcinoma in situ for breast cancer, but they live with that. And then if they've got a clinically significant cancer, yes, let's get on and treat it. I have to retain an open mind. We are currently, all the evidence is being collated, and there is health economic modelling being done on it, and we should have the results of that within a few months. I can't give you an exact date because I don't know it, and we will then take that to the screening committee. I suspect it'll be one of the more difficult decisions that the screening committee has to make, but that's our job. So believe you me, I'm open to the possibility, but I do need the evidence first.
Thank you.
And Mike, it'd be helpful maybe, would you be able to expand a bit more? I know you touched upon it about the evidence of how you're thinking about these things, because I've seen more and more, and I think colleagues would have seen this as well, where a lot of campaigns now are mobilising the public and the general public to put pressure, aptly so, because they've lost a loved one, and thinking like, well, what more can the government do, or what more can screening do? How do you make these decisions? Because we've seen some kind of lobbying from MSED companies, very public, very noisy. We've seen that obviously from everyone who's really interested in but it's a complex decision, because it's not just about the outcome, it's about complications, about cost. So talk us through, if you can, about that process.
So with any suggested screening program, first of all, we have an annual call for people to put in proposals. I want screening of cancer of the big toe. That would come into us. We would say, is there any evidence that screening for cancer of the big toe is a good thing? And so we would fairly rapidly be able to exclude that one. Somebody can tell me if I'm wrong, but I think that's probably fair. If there is some evidence, we do what we call an evidence map, where we just look at what is the weight of evidence, and that's of stage 1, and then stage 2 is doing a detailed evidence review. If the detailed evidence review says there really could be something here, then we will go to modelling of cost effectiveness, similar to a process that NICE would do, but again, in the back of our minds, there's what's the benefits, what's the harm, what's the cost. There are technically 20 different criteria, but I can remember those 3. Actually, I can. No, don't put me to the test now. But there are 20 tests, and they're all useful because, what, for example, what is the pathway after you've made? It's not just about the test, but what is the whole pathway, and is this going to lead to lives being saved? And by the way, we're doing this for newborn screening as well as for adult screening. So which test should be on the blood spot test for newborns? That's even more complicated. Tyrosinemia. I challenge anybody in the room to have seen a case of tyrosinemia. You may have done. There are 7 in the country per annum. But we've been through that. We think it is cost effective, so we are now adding it to the blood spot test. We will have to make decisions on whole genome sequencing in due course. That's going to be even more tricky. So we have a process, and ultimately we then have 2 subcommittees, one that deal with the newborns, one that deal with adults. They look at it first. If they think there's a sufficient case, it comes to the committee that I chair, which has a range of different experts, including ethicists, including public health, including health economic modelers, including a whole range of experts who will then wrestle with this and try and come to a conclusion. So it's a very detailed process. People say it takes too long. I think it does. I'd like to see it speeding up. But equally, we do now have the opportunity, which has only been with us for the last couple of years, of looking at targeted screening programs. So, for example, it might be, going back to the prostate cancer example, it might be that it's not cost effective for the population as a whole, but it might be in groups that are at higher risk, people with a family history. Chris Hoy would fit into that category. People from certain ethnic backgrounds, black populations at considerably higher risk. So those are things we are considering as well as looking at whole population screening. In other words, every man between the age of, let's say, 50 and 79 or 45 and 79. So we're looking at those options as well.
Brilliant, thank you. Any questions? Diana? Yeah.
Thank you so much for your comments and your thoughts. I have a question from the US-UK perspective, which is that we have targets for screening, much like you do, and we spend a lot of money to get to those targets because there are financial incentives, as opposed to doing it because there is a decrease in the cost of cancer treatment and care. I wanted to pick up on the question about home HPV tests, in part because I've done 2 very large randomized trials demonstrating that uptake is much harder to attain in underscreened individuals with self-collect and much easier to attain in people that are up to date, that are coming due. And the preferences from females that do this are to have a choice for a variety of reasons. But we had to start in the States with the same evidence that you had to start with in the UK, which is underscreened, because of the slightly lower effectiveness, efficacy of the self-collect. But I wonder from the, how does your committee take into account that it costs a lot more money to reach the people that are the hardest to reach, and that delta of increasing screening is going to be the smallest in that group? And that's what we face with, for example, self-collect, which is that it costs a lot more money to send out tests to everybody, but you're reaching the hardest to reach individuals. And the U-Screen trial had a really incredible uptake, but it was because they were in GP practices to begin with. The people that aren't getting screened aren't in GP practices. They're the people that work in the grocery stores. They're the people that don't have time to make it to clinical appointments. And I look at the UK as a system of saying, you know what? Everyone matters here, not like the United States, because if you're not insured, you don't matter. But here in the UK, everyone matters. And therefore, it actually may be more cost-effective, not from the cost-effective traditional analyses, which is number needed to screen, but once you take into account the costs of care for the individuals that you're not reaching, I think that you would see a very different assessment. And I don't know to what extent your committee does things like that, and I'm just curious to hear from you on that.
I suppose I would say that what we do is take it one step at a time. You know, we've got the evidence from the U-Screen trial for doing what we're doing. We've made the recommendation. I'm glad to say that ministers accepted it. I'm glad to say that NHS England is now going to implement it. We will learn a lot as we implement. And the question earlier about exactly how we implement that, I think there's a lot to learn about that. And should we be going straight to the underscreened rather than doing it through the GP surgery? I have no doubt that things will not stay static. Exactly how we do it in 5 years' time, I don't yet know, but I can't believe it will stay static, but at least we're taking the right first step in getting self-sampling, in getting people understanding that. I mean, and there are, I hardly dare say this, but there's going to be people who would prefer self-sampling. Are we going to see people not going for their routine screen in order that they then qualify for self-sampling? There you are. So we are watching for that, and that may give us a direction of travel. So watch this space. I don't think I can say more than that at this stage, but it's a really good question.
Thanks, Diana. Next question. I think it was you. Yeah.
Hi, thank you so much for your time. I just had 2 questions. So the first one is about, we're seeing a lot of cases of young breast cancer, young bowel cancer.
Yeah.
But obviously our cancer screening for those start quite late and later than other countries. Is that something that's under review? I think we have a lot of people have personal people in their lives who've gone through it, or patients that they've known well who've gone through it and had these cases in their 30s and 40s rather than 50s.
I think the Western world as a whole is worried about the young cancers, both breast and colorectal in particular. I know this is a major issue in the USA as well. We haven't reached any conclusions on that. As you will know, for bowel cancer, colorectal cancer, our main limitation is our endoscopy capacity, which really worries me, and we're doing everything we can to try and improve that. We are, the threshold on the FIT test before you get to referred on for colonoscopy is frankly far too high. It's 120 in England, it's 80 in Scotland, and all the evidence is that it should be below that in both countries. And equally, the age range, we are bringing it down. We started off 60 to 74. It is coming down and will be at 50 to 74. But the thing that's the rate limiting factor is our endoscopy capacity. But will we get beyond 50? I think if the evidence is there, yes, we will, and I suspect it will be. I think in the meantime, we won't be screening the asymptomatic under the age of 50, but we do have tests for people with symptoms. Would I like to see a wider use of the FIT test in under 50s who've got symptoms? I would say, why not?
On that, Mike, Somerset's launched a FIT pathway for patients under 50. We'd love to share the results with you on that.
Do please.
That's definitely something that's on a population self-referral for FIT under 50.
Do please. And breast cancer, again, there is... First of all, we do have the AGEX trial, which is looking at women not under the age of 50, but only down to 47, and women above the age of 70 up to 73, and we will be getting the first results of that. It's a massive trial, but we get the first results of that before very long, within months, and probably the full result in terms of mortality by 2027, something like that. Do we need to be aware that breast cancer can affect people under the age of 50? Of course we do. But I don't see us suddenly screening the whole population. But again, should we be doing groups that are at higher risk? Yes, we already do for people who are known to carry the BRCA1 or BRCA2 gene. It's a tiny number that we know about. We only screen, I think it's less than 10,000 women a year in that group. We think in the population there are at least 10 times that number, if not 20 times that number. So it's how we find those. But we do then start their screening right down at age 30, and we do it more intensively with MRI. So I think there is a question of, can we identify the high-risk groups to be able to screen those at a younger age? You want to come back, don't you?
That's good. Sorry, just a second part. Just as a GP, I've only worked as a GP for 6 years, but I can see in the last few years, my routine referrals used to take 2 months maximum. and now they're taking 6 to 9 months, and then sometimes it'll be a telephone appointment, and then the patient will get their investigation. So all of our referrals for symptomatic patients that don't meet 2-week wait criteria, by the time they're actually investigated, a lot of cancers are presenting in secondary care when we know what tests are needed, but because of the delays in routine appointments as well, it must be having an effect on our cancer diagnosis.
And that comes back to giving GPs better access to diagnostics and helping the GPs to know which diagnostic it is. Brackets, see the signs.
Cherry?
Am I giving it enough plugs?
Hi, thanks for that. I'm the policy lead from Pancreatic Cancer UK, and my question's around surveillance of people with inherited pancreatic cancer risk. We funded the EuroPac study, which offers surveillance for people with inherited risk over the past sort of 10 years. We've worked with NHS England as well to invest into that study. And I guess just like looking forward now, what do you see as the best way for the Department of Health with the cancer plan to deliver that sort of surveillance service at a national level?
Well, if we can demonstrate through that sort of trial that actually for people at high risk we can pick it up early and make a difference, then yes, we should do it. And so that would be a classic of where, you know, when the evidence is there, make sure that you respond to the annual call for proposals for screening. We will then pick it up, look at the evidence, and take it through from there. So we're not opposed to that at all. It's just I need to be shown the evidence that it will actually make a difference.
No, and that makes total sense, I guess, from a national screening perspective. But I guess where there already is a service at a national level, and we kind of intuitively know it's probably a good thing, how do we, is there a way that we can run that at a national level? I don't mean a screening program, I mean just that bit below where there's some evidence and we're still trying to generate that evidence. How do we run that nationally?
If you want to run it, I think we need a discussion offline. But if you provide us with the evidence that you've got, in some cases, what we can actually recommend is a so-called in-service evaluation. In other words, can we gather more data by doing it not at national level immediately, but at those places that are already doing it. So we do have a mechanism for thinking about that, but we would need to be shown what evidence you have got first.
Yeah, that makes a lot of sense. Yeah, thank you.
Any other questions just to wrap up? Final question just behind you, yeah.
Very quick question about cancer, breast cancer. Not only to screen people earlier, but maybe the window between screening being shorter, because 3 years, I think you compare with European countries, is quite a lot. And I did recently an audit for my surgery. 3 people were diagnosed through screening, and by chance, they have had the screening 2 years before. I don't know why they had the screening a year earlier, and 3 of them were diagnosed of cancer.
So, yes, I absolutely recognise that we do it at 3 yearly intervals and other countries do it at either 1 or 2 year intervals. At the moment, do we have the mammography workforce to do it more frequently? No, we don't. There's a whole lot of things we would need more people to actually do the mammograms. Then there's the question about interpreting the mammograms. That's something with AI. We do need to have really robust evidence before we can say hand it over to AI, but we may get there, or we may at least get there in terms of 1 human, 1 AI machine, as opposed to 2 humans. We do have the best, and it's better than the United States, by the way. Let's just say that. In terms of having 2 humans read our reports, even though it's only at 3 years, it has much better in terms of what the recall and the pickup rates are than some other countries. So I wouldn't want to lose that, but I do think we might be able to move to 1 human, 1 machine, if you like, but we need to get the evidence before we do that. Then the other bit is that we also ought to be thinking, can we identify the people who are at higher risk? So, for example, women with dense breasts are both at higher risk of breast cancer and higher risk of it being missed on a mammogram. And so I think that over the next few years, are we likely to have a different strategy for women who are at higher risk? Can we identify them? Yes, we can the first time they have a mammogram, and that there are now actually AI techniques for measuring density, and then could we have a different program? That's still in development, but there is some quite exciting research coming through on that.
Brilliant, thank you. Will you be joining us for the drinks reception?
Surely not.
I was going to say you guys can approach Sir Chris then for any questions. But Chris, just to wrap up now, do you want to leave us with any final thoughts about, you know, what you're optimistic about, what you're really excited about?
I'm excited about prospects, particularly in terms of technology and AI. And I think we could do a lot better with the resources we've currently got. Will I make the case for more resources? Yes, I will. But knowing what the country's economic situation is, we've got to make the best use of what we've already got, do things differently. That's where I think that tech and AI can really be valuable. And I'll say it once more for your benefit, AI includes see the signs.
Thank you so much, Sir Chris, everyone. We're just going to finish, guys, with the votes, if some of you will recall. So if you are able to scan the QR code, the first vote is for the poster presentations. And if you just scroll, you will see the all 7 presentations listed once you scan the QR code. And you'll find that you can only vote for one, so just so you know. We do have all 7. I think the AV team are just about to scroll. There we go. So you should be able to see all of them. I'll just give you a few minutes, and then we'll move over to the oral abstract presentations to vote for your favourite one. Can I move to the next slide? Yes, I see nods. So this is for the oral presentations that you heard earlier today. So you have the 4 oral presentations that you received with the details of the presenters and the abstract titles. Again, we'll scroll just to show all 4 on the screen, but it's the 4 that you saw this afternoon on the stage. So as you do that, just to say, I want to say a big thank you to all the speakers. We couldn't have done this without you all. I'm just going to move on to the closing slide as you finish that. Just to say from kind of our closing remarks at See the Signs, for every patient we see too late, there was a moment we could have seen them sooner. Our work is to find that moment and never miss it again. And that really is kind of the essence of this conference, which is the first of our annual conferences that we are kicking off at See the Signs. I can't thank you enough to all the guests, the speakers, for all of you to take a day out of your busy lives in coming down to London, which is often not easy to get to as well. So we really appreciate it. To all the abstract presenters and poster presenters, thank you so much for finding time again in your busy lives and busy practices in putting together research and understanding the value of doing research and thinking about how we can improve patient outcomes, when often it's at the bottom of the list of a busy clinic and a very busy document workflow and workload that you have to do. And then lastly, like, none of this would have happened without the See the Signs team. I can't tell you, we had a very short space of time to put this on and get it together. So I can't stress enough to Katie, who's over there on the camera, who led a lot of this, a huge thank you. But to the entire team, Nicole, Cherry, Nikki, Jess, Miles, I'm trying to see some James and Cherry, obviously for doing the mics today, the rest of the team as well, and Drula, John, and also the team that flew in from the US to attend this conference. Thank you so much to you all. And thank you again we will send out a save the date for next year, but also most importantly, this is a CPD day. You can claim 5 hours of CPD, so please scan the QR code. We'll send that out anyway afterwards. And once you do the feedback, we can then send you through a certificate for the event. So thank you so much, and please join us for the award ceremony downstairs and a canapes and a drinks reception. So thank you so much.